At the outset, I want to put on record my sincere thanks to Professor Noor and other members of ESD conference who have given me this opportunity. In the technique section, let us first of all know whether we should put our position in patient in supine position or prone PCNL. I have no conflict of interest. I hope my slides are moving. Can anyone tell me? Hello?
Yes.
Yes, they are moving. They are okay.
Okay. So we are going to discuss whether to put the patient in prone PCNL, prone position or in supine position. In prone position, it is so tempting to put the patient in prone because kidneys are so close by and track is going to be really very small. Not only in thin patients, but even in morbidly obese patients, track length does not increase much. It may increase just by a centimeter or two because most of the subcutaneous fat responsible for morbid obesity lies anteriorly and not at the back. In such a huge individual in whom two people were required to lift his anterior abdominal wall so that I could do cystoscopy, when the patient was turned little bit on the other side, even then a puncture in supine position was not possible. You can appreciate that. Ultimately, we had to turn the patient prone, and believe me, track length was not so much. It was just a centimeter more than the normal. Another point about prone PCNL is there is no important structure behind the kidneys. Embryologically, kidneys develop from mesonephros. They are always situated posteriorly and only muscle, fat and skin is there posterior to that. While making this comment, I am aware about 1.9% of the cases in supine, retrorenal colon will be there and colon may come posterior. But when the same patient is turned prone, in 4.7% cases colon moves posteriorly. In a larger study of more than 380 cases, there was this incidence of retrorenal colon was almost 7%. But we don't see so much colonic injuries in prone PCNL. So even then, when the kidney is situated higher up, maybe in the thorax, in an abnormal position, it was still behind the heart on the left side. And I could very easily do a PCNL in this case because kidney is always posterior and not anterior to any significant organ. Even posteriorly, kidney could be approached from behind and prone PCNL was possible. The most important point of prone PCNL is prone positioning provides you a much wider field for straight, well-aligned access to avoid torque. According to the line of infundibulum, alignment with the infundibulum, you can go from anywhere, east, west, north, south, anywhere you can plan and you can make a puncture. Our nephroscopes are rigid stainless steel instruments and it is always better to pass a straight instrument easily in alignment. Even if you are doing a supracostal puncture and if you remember it to remain lateral to the mid-scapular line, such a huge area is available for making a puncture. You can go as medial as through the lateral border of the transverse processes. You can go through the paraspinal muscles also, or you can go from anywhere between 10th and 11th rib, between 11th and 12th rib, up to the anterior axillary line, posterior axillary line. All this area is available to you when you are putting the patient in prone position. Particularly regarding superior calyceal access, which I like for all my staghorn stones, when the patient is prone, because we know in the superior calyx 98% of the times the superior calyx has got one medial portion and one lateral calyx. In supine PCNL you can only enter through the lateral portion of the superior calyx. while in prone position you can enter straight from the tip of this in the medial calyx, and medial superior will take you down right up to the PUJ, right up to all these structures. Most of the stone bulk you can see, you can appreciate, can be removed through a straight nephroscope without offering any torque to the track. So prone PCNL will help you in all these situations. If we talk about some unascended kidneys, any calyx which is popping up in this area, such a huge area, can directly be punctured. Like if you see, this was a stone in an unascended kidney, and this is the inviting calyx. In prone PCNL, you can directly puncture this calyx and go and gain entry into the pelvic calyceal system. Another stone just at the L5 vertebra, and you can see this is the inviting calyx in which a prone PCNL is possible. You can gain entry. Crossed renal ectopia, so many stones you can see in this kidney, and all this in a prone PCNL. I could make a track from here, and once the track was made, these particular stones were removed, and these stones which are there in these calyces, they were pushed with the help of saline, a direct needle puncture, bullseye puncture into this calyx, and then flushing will bring all the stones in the pelvis, and you could remove it easily. All these stones could be removed in prone PCNL. So it's a very versatile technique. So many stones you can remove, and particularly in 12% individuals where there is a parapelvic calyx, you can identify a parapelvic calyx like this, which has got a narrow infundibulum. This can very easily, comfortably be approached by a bullseye technique of puncture in prone position, and you can tackle this stone. So this is the versatility of prone, and even in prone PCNL there is some complication, some extravasation like spillage of stones, hematoma, urinoma, or even if there is a colonic injury, the colonic contents will only leak out retroperitoneal, and extent of damage and injury and septic complications will be limited if you give a free drainage to the extraperitoneal space. Coming to supine, it is not a new technique. Way back in 1987, Valdivia had mentioned a simplified technique. He had shown a supine PCNL is possible through this area just by offering a little tilt to the patient and entering the kidney from this area. He was so convinced with this technique, in after 3 years, when he had finished about 280 cases, he published Why is percutaneous nephroscopy still performed in the prone position? And you see the statement he made is relation to that. Supine position offers greater ease and safety to both the patient and the surgeon, making it possible for the operation to be carried out even under local anesthesia, and it permits simultaneous transurethral access to the homolateral ureter and kidney. This statement was made 32 years ago, but supine PCNL has come in big way in last 10 to 15 years only. Supine PCNL was really welcomed and preferred by anesthesiologists. All of us know that. They mention it gives rise to less risk of injury, less risk of thromboembolism, improved ventilation and access to the neck and for the ventilation, and no need of extra anesthesiological equipments. A comparative study in ASA grade 1 and 2 patients showed in 20 prone versus 20 supine PCNLs were compared, and they clearly mentioned it causes less hypotension, significantly less fluid absorption, and less anesthesia time, so it is safer. Even in ASA grade 3 patients, this Indian study done at Nadiad by Mahesh Desai group, they also mentioned that supine approach of PCNL was found to be safer for anesthesia point of view. So these are the advantages of supine PCNL. It gives you optimal cardiovascular and airway control. It is better in high risk patients. No patient repositioning is required. Better stone fragments wash out. But once we are doing prone PCNL and our method of entry into the kidney is through the gradual descent technique, again our employed sheath is horizontal, just like in supine PCNL. So that also drains equally. Anyway, there are so many advantages and disadvantages mentioned about supine PCNL, and similarly, prone PCNL has got its own advantages and disadvantages. As I mentioned and showed, prone PCNL has wide surgical field for renal puncture, more potential access sites, and I have always seen, not always, but quite often, a patient who was being done in supine PCNL, and if there was any problem, he was turned to the prone position. I have not seen vice versa. So for urologist, a good access is possible with the prone position, that is undoubtedly. 9 studies were compared, 5,000 prone versus 1500 supine were evaluated, and this Chinese study mentioned that stone free rates are significantly low in supine PCNL. Later on in 2016, when 5,600 cases of prone were compared with 2,110 supine cases, it was found in these review of 20 studies, there is a similar stone free rate, similar operation time, similar hospital stay, but supine patients had less fever and need for blood transfusion. So picture is becoming clear, and our own Dr. Noor, he and his group have studied literature review of 30 articles, and they have mentioned there is no significant superiority of either approach. So it remains a personal choice, training of the surgeon, and it is still debatable that any technique is better than the other. Even colonic injuries have taken place in supine position as they are in prone position. There is no difference. So let us have some take-home messages. Supine position for PCNL has many advantages for the anesthetist. Very true. It allows access to those patients who cannot be put prone, like in COPD patients, kyphoscoliotic patients, and obese patients. And maybe they say that by avoiding a hazardous turn to prone, there is less injuries, less chances of injuries. But if you have an experienced team who have already done thousands of cases from supine to prone, there is hardly any difference it makes. So these are all the take-home messages, and with this I thank you all for listening to me patiently and for your kind attention. I take this opportunity to invite all of you to New Delhi on 1st and 2nd of October, where we are holding 9th International Live Operative Workshop on PCNL. Live cases will be demonstrated, and this is called PERCON 2022. Thank you very much for listening to me so patiently.